Now we will continue with the second lecture of the MCQ series. Our next MCQ is, where does the myelination of the ganglion nerve fiber commences or starts? The options are: upon exiting the lamina tuberosa, within the retinal nerve fiber layer, optic nerve head, in the distal third of the intraorbital optic nerve. So the correct option here is upon existing the lamina cribrosa. Lamina cribrosa is also known as the cribriform plate. Remember that there can be a variation in the MCQ in the original exam. Cribriform plate. So it is a sieve-like structure in the sclera. Sieve-like structure in the sclera where the optic nerve exits the eye. The next question is, which of the following statement is false about corneal endothelium? The questions like the false, they can be asked like, which of the following is least likely about the corneal endothelium? So remember this, the MCQ can be modified like this in the real exam. The options are: the cell contains large numbers of mitochondria. The cells become more homogeneous with age. The cells have a low regenerative capacity. The cells are polygonal in shape. So the correct option here is the cells become more homogeneous with age. No. Thus, corneal endothelial cells become more heterogeneous, less uniform. So there is more irregularity of the structure with age, taking on a variety of shapes rather than the regular hexagonal pattern typically in the young. Next question is, which of the following statement regarding the open angle glaucoma is false? The options are: temporal nerve fibers are more susceptible to damage than the nasal fibers. Fibers from the papilomacular bundle tend to be spared. The optic cup is enlarged more horizontally than the vertically. Mutations have been identified in the GLCA1 gene in some families. So we have to choose the false statement regarding the open angle glaucoma. So the correct option here is Charlie, because the optic cup is enlarged more vertically than horizontally. Remember this, that there was written more horizontally. No, it is not more horizontally, it is more vertically enlarged. Let's have some discussion over the other options. Papilomacular bundle tend to be spared. These are least affected. It means these are least affected, can be asked in either way in the MCQ. Least affected, and these are responsible for tunnel vision. Tunnel vision. Responsible for tunnel vision. The next question is, which statement is false about the sclera? The options are: it is covered posteriorly by the conjunctiva, it allows the passage of the optic nerve through the lamina cribrosa, it consists of three layers, the innermost of which is lamina fusca, it is composed of irregularly arranged collagenous lamellae. So the correct option here is, it is covered by posteriorly by the conjunctiva. No, this is not covered posteriorly by the conjunctiva. Rather, it is covered it is covered anteriorly by the conjunctiva. And what is posteriorly? Posteriorly by the fascia bulbi, also known as the tenon capsule. Remember that. So here it is written that it consists of three layers. The sclera consists of three layers. What are these three layers? These are episclera, episclera, stroma, and third one is lamina fusca. So our next question is, all of the following are true about the retinitis pigmentosa except retinitis pigmentosa is a disease of the retina. The question says that all are true about the retinitis pigmentosa except the options are: individuals are typically affected in the early adult life. It can lead to the tunnel vision. Retinal atrophy is evident with the fine, coarse strands of pigmentation. Retinal vessels are relatively unaffected. It causes the night blindness. So the correct option here is retinal vessels are relatively unaffected. No, retinal vessels are affected. So what is RPI? Is a heterogeneous group of the condition which can be caused by a host of mutations, some of which code for the rhodopsin. This is very important, that the most important gene responsible for the retinitis pigmentosa is that codes for rhodopsin. In addition to the peripheral retinal atrophy with the streaks of pigmentation, there is peripheral retinal atrophy. That's why there is tunnel vision. Okay. There are bone spicule appearance. Microscopy reveals the evidence of the retinal vessel attenuation and the halinization. It means that retinal vessels are affected. So it leads to the retinal vessel attenuation, narrowing, and thickening and glossy appearance of the vessels. And glossy appearance of vessels. The next question is, which of the following statement is false regarding the retinoblastoma? The options are: metastatic dissemination is usually via the lymphatics. It may be successfully treated with radiotherapy and the chemotherapy. It appears macroscopically as a smooth white mass. It is due to mutation in the tumor suppressor gene. So we have to choose the false statement here. So the correct option is metastatic dissemination is via the lymphatics. No, it is via bloodstream. No, it is not via the lymphatics. It is via bloodstream. A very important. It is treated with radiotherapy and chemotherapy. It is caused by the tumor suppressor gene. It appears as a smooth white mass. In diabetic retinopathy, which of the following changes are commonly observed? The options are macroaneurysms, increased number of parasites, cotton wool spots due to nerve fiber ischemia, thinning of the capillary basal membrane. So, what changes observed? These are the cotton wool spots, and I have already told cotton wool spots are formed due to nerve fiber ischemia. Very important. And what about the other options? In diabetic retinopathy, the capillary basal membrane is thickened. There is no thinning. There is thickened. There is decrease in number of parasites. Remember all these changes. Microaneurysms. Microaneurysms are present, not the macro. Cotton wool spots, I have already told. Which of the following statement about the myelination of the optic nerve is false? The options are myelination begins during the 7th month of gestation, myelination is completed after birth, myelination progresses posteriorly from the lamina cribrosa, myelination allows more rapid transmission of the nerve impulses. So the wrong option here is myelination progress posteriorly from the cribrosa Charlie because myelination starts in the 7th month of gestation and is completed about 1 month after the birth. Myelination starts at the chiasm and progress towards the lamina cribrosa. It does not goes posteriorly from the lamina cribrosa. It grows towards the lamina cribrosa. A very important point. So this is very important that begins during 7th month and completes after birth. 1 month after birth. Okay, very important. And correlate this question with MCQ 41. Our next question is a full thickness stab incision located 11 millimeter superior to the eyelid margin or the pupil in the Caucasian upper eyelid would be close to each of the following structures except. So the incision is given 11 millimeter superior to the eyelid margin. So what will be the structures present and which structure will not be present? The options are superior dorsal muscle, peripheral arterial arcade, gland of mole, and the orbital fat. The correct option is Charlie. It will not be present 11 millimeters superior to the eyelid because these are present at the margin of the eyelid. At the margin of eyelid. The other structures are present 11 millimeters superior to the eyelid. So our next question is where do the orbital floor fractures most commonly occur? Orbital floor fractures most commonly occur. A very important question. Orbital floor fracture. Read it from Ramesh controversy portion. Okay. A very detailed written there portion. So where does the fracture commonly occurs? The options are along the inferiorbital canal, within the zygoma, medial to the inferiorbital canal, within the zygoma, medial to the inferior orbital fissure, within the maxilla, medial to the inferior orbital canal. So the correct option is delta, within the maxilla, medial to the inferior orbital canal. The next question is what is the correct order of the structures that would be encountered when the upper eyelid is penetrated 14 millimeter above the eyelid margin. 14 millimeter above the eyelid margin. This is the question asked in other way. There was a previous question as well. So what would be the structures present when there is incision at the 14 millimeter? This is simply the layers of the eyelid. You have to remember from the Ramesh. The options are preseptal, orbicularus muscle, orbital septum, levator aponeurosis, and the Muller muscle. So the option A is correct here. This is simply the layers of the eyelid in a correct order. This question can be asked in a simple way and can be asked by giving a scenario like this, that the incision is given 14 millimeter, there is a injury and the eyelid is penetrated at 14 millimeter. So remember all these scenarios in your mind. Which of the following statement about the lenticular disorders is true? The options are: microspherophakia is most often associated with Marfan syndrome. In Lowy syndrome, there is typically cataract, glaucoma, aminoaciduria, and the girls are affected more than the boys. Cataract is congenital rubella syndrome are generally dense nuclear cataracts. Defects in the rubella syndrome are typically isolated. There are usually no other systemic abnormalities. Glaucoma and the cataract are frequently coincident in the congenital rubella syndrome. So we have to choose the right one here. So the correct option is Charlie. Cataract in the congenital rubella syndrome are generally dense nuclear cataract. Why the other options are wrong? Let's study here. Microspherophakia. Spherophakia means the lens is spherical. Lens is spherical and small as compared to its normal biconvex shape. Normal biconvex shape. This is observed with Weil-Marchesani syndrome. Very important and not commonly in the Marfan syndrome. Patients with the Marfan syndrome are usually tall and lean in contrast to the patient with Weil-Marchesani syndrome, which are short and stocky. These are short and they have the broad structure. Marfan syndrome is often associated with ectopia lentis. Ectopia means abnormal position of the lens. Ectopia lentis means abnormal lens position. Lowy syndrome is inherited as an X-linked recessive fashion. So it will be more common in men only. Okay, there was written that girls are affected. Any organ in the body may be damaged by the rubella, and the rubella syndrome is characterized by the triad of cataract, deafness, and the cardiac defects. Please remember this triad of rubella syndrome. Juvenile glaucoma and the cataract rarely coincide with the congenital rubella infection. So our next question is, which of the following statement about the genetics of the aniridia is true? Aniridia means absence of iris. Absence of iris or very little iris tissue. Which of the following is true? The autosomal dominant form is the only form to feature the aniridia with no other ocular abnormalities. The aniridia associated with the Wilms tumor is most often inherited. Aniridia is usually sporadic. When confronted with the patient with the newly diagnosed aniridia, an ophthalmologist should undertake a careful examination of the patient's family members. Most cases of the aniridia are unilateral. So the correct option here is that delta. When confronted with the patient with the newly diagnosed aniridia, an ophthalmologist should undertake careful examination of the patient's family members. So why the other options are wrong? Let's study that there is sporadic aniridia, which is the non-familial, means non-hereditary, is often associated. So this is associated with glaucoma, cataract, can be caused by a new deletion in the of the interstitial segment of the chromosome 11. Remember this chromosome. NADDI is associated with abnormality of the chromosome 11 and short segment P13. This deletion also results in the genitourinary malformation, which may be subtle in the females, mental retardation, and the Wilms tumor. So, the sporadic aniridia or the non-familial, that deletion is associated with the Wilms tumor. Remember that. This is not hereditary. Hereditary Hereditary aniridia can occur with the autosomal dominant or the autosomal recessive inheritance pattern and is associated with the other ocular anomalies, including the nystagmus, cataract, glaucoma, and the corneal abnormalities. And there is also hypoplasia of the optic nerve. So, hereditary aniridia are also associated with ocular abnormalities. There was written that the autosomal dominant form is not associated with the ocular abnormalities. The next point is hereditary aniridia is rarely associated, I have already told, with Wilms tumor. Examination of the family member differentiate the sporadic from the hereditary aniridia. Most cases of the aniridia are bilateral. Okay, bilateral. And the 2/3 of the cases are familial. 2/3 of the cases are familiar. It means that usually the aniridia is hereditary, not sporadic. Here it was written that sporadic. So remember each of these lines. Our next question is, which of the following is the main reflex tear secretor? Reflex tear means that there is some kind of stimulus that leads to the tear production. We all know that the accessory lacrimal glands, the glands of Cross and the Wolfram, are the basic tear secretors under the normal conditions, while the main lacrimal gland is the reflex secretor. So the option is Charlie is correct. Main reflex tear secretor. Don't mix it with the basic tear secretors, which are glands of Cross and the Wolfram. And how the lacrimal gland is activated? Stimulation of the first branch of the trigeminal nerve can induce the tearing through the reflex arc. Meibomian gland. What the meibomian gland does? Secrete the oily fluid for the lipid layer. Okay, oily fluid for the lipid layer. The next question is, which of the following contribute to the aqueous layer of the tear film? The options are glands of Wolfram, gland of Zeiss, goblet cells, meibomian glands. So the next question is, so the option correct is glands of Wolfram. The aqueous component of the tear film is secreted by the main lacrimal gland, gland of Cross, and the glands of Wolfram. So here the option was Wolfram. The goblet cells secrete the mucin layer. The meibomian gland secrete the lipid layer with some contribution from the sebaceous gland of Zeiss. Okay. So remember all these. So our next question is, which of the following best describe the cellular reaction when the light strikes a photoreceptor? So what happens when light strikes a photoreceptor? The options are increased CGMP level, closed sodium channel, increased CGMP level, and the open sodium channel, decreased CGMP, and the closed sodium channel, decreased CGMP, and the open sodium channel. So it will be decreased CGMP level and the closed sodium channel. Let's see how this happens. Look here, when light strikes a photoreceptor, the rods, cones in the retina, the following sequence occurs. Light activates the rhodopsin, which activates a pathway, G protein coupled pathway. This pathway activates the phosphodiesterase, which breaks down the CGMP and reduces it. Okay, decreased CGMP then leads to the closure of the sodium channels, and this closure of the sodium channel lead to the hyperpolarization of the photoreceptor wall. This is very important, this pathway. Any MCQ can be asked from these points other than the MCQ I have mentioned here. So the next question is, which gland are responsible for secreting the lipid layer? We have studied this already, that what are the options? Gland of Krause, Wolfram, dorsal meibomian gland, and the lacrimal gland, palpebral lobe. The correct option here is dorsal meibomian gland. Charlie. The next question is, which of the following topical beta blocker would be best suited for the someone with mild bronchoconstrictive disease? Bronchoconstrictive disease. The options are timolol, bitoxolol, metoprolol, levobinolol. So basically, all these are the beta blockers. So the correct option among these is the bitoxolol. Among these, because look here, that all of these drugs are contraindicated. We can say that all these drugs are contraindicated, but there is one drug with some safety level we can use in the bronchoconstrictive disease, and that is bitoxolol. All of these agents are the adrenergic receptor antagonists, beta blockers. Okay. However, bitoxolol is beta 1 selective, so it does not act on the B2 receptors to block the lungs, making it better choice in patients with pulmonary disorders. So our next question is, which of the following IOP lowering therapy would be least suitable for a patient who has bronchoconstrictive lung disease? So that was the question. We can use what we can use, and now what we cannot use. Least suitable for a patient who has mild bronchoconstrictive lung disease. Compare both of these questions, that what drug can be used with bronchoconstrictive disease and which drug cannot be used. So the correct option here would be timolol. Timolol. Because it is a beta blocker. Bitoxolol is a, I have already told that it is a selective beta 1 blocker, so it can be used, and the other drugs can also be used. Timolol and the bitoxolol are both beta blockers. However, bitoxolol is a beta 1 selective, making it a better choice, because which is with the pulmonary disorders, which is non-selective. Non-selective agents can inhibit. I have already told that the non-selective agents will inhibit the beta 2 pulmonary receptors and can lead to the significant bronchospasm in the susceptible patient. Etenoprost is a prostaglandin analog, and brimonidine is alpha 2 agonist. It is not the blocker, it is the alpha 2 agonist. So these drugs can be used. So in the STEM must read what is being asked. Look here, that the drug can be used and the drug cannot be used. I am emphasizing again and again, because in the original CPSP exam, there are many MCQs like these in which you are confused with words. So our next question is, a lady presented with the severe sudden onset of pain, corneal congestion, photophobia, and the deep anterior chamber in the right eye. The left eye is normal. X-ray pelvis shows the sacroiliitis. So X-ray pelvis shows the sacroiliitis. So It is because it is referring to the uveitis, so most it will be anterior uveitis. Anterior uveitis. Sudden onset of pain, corneal congestion, photophobia, deep anterior chamber. All these are pointing towards the anterior uveitis case. The next question is a 75-year-old patient present with the deterioration of the vision. On examination, the pupillary reflex is observed to be sluggish. Remember that there is no sudden decrease of vision. This is slow deterioration of the vision. Intraocular pressure is normal. Optic disc evaluation shows a large and deep cup. Positive findings are these: large and deep cup, and shows paracentral scotoma. The most likely diagnosis here is because the IOP is normal, but there are changes, large and deep cup, and there is paracentral scotoma. So the options are primary narrow glaucoma, normal tension glaucoma, neurovascular glaucoma, and absolute glaucoma. The correct option is normal tension glaucoma. There are glaucomatous changes, but the IOP is normal, so that's why it is the normal tension glaucoma. The next question is inclusion with multiple recurrences at the same site with the incision and the curettage should be. We have done the incision and curettage, but there is again the collision. So what should be done? So followed by cauterization with carbolic acid, preceded by cryotherapy, preceded by intralesional injection of the triamcinolone, replaced by excisional biopsy. So it there should be excisional biopsy to rule out the malignancy. The correct option is that. Our next question is a 20-year-old male complains of difficulty in reading the newspaper with his right eye. 3 weeks after sustaining the gunshot injury to his left eye, the most likely diagnosis is. The options are macular edema, sympathetic ophthalmia, optic nerve avulsion, delayed vitreous hemorrhage. Remember that there is a history of gunshot injury to the left eye, but he is unable to read with his right eye. So the option correct here is the sympathetic ophthalmia. This is the condition, a rare bilateral granulomatous. Okay, it occurs. It occurs after trauma or surgery. After the trauma or surgery in one eye, that is called the exciting eye. The traumatized eye is called as the exciting eye, causes inflammation in the second uninjured eye. Remember this, okay? Second uninjured eye. That is known as the sympathizing eye. So this is known as the sympathetic ophthalmia. The next question is a patient present with acute painful red eye and vertically oval mid dilated pupil. Most likely diagnosis is. The positive findings are acute painful red eye, and pupil is also mid dilated, oval mid dilated pupil. This is the most common findings of acute angle closure glaucoma. So our next question is A 55-year-old female comes to the casualty department with the history of the severe eye pain, redness, and the diminution of the vision. On examination, the visual acuity is 6 by 60. There is circumcorneal congestion, corneal edema, and a shallow anterior chamber. Which drug should be given first? So, first we have to make the diagnosis quickly. There is severe eye pain, there is redness, there is decrease in the vision. Okay, there is corneal congestion, corneal edema, shallow anterior chamber. All of these are pointing to the acute angle closure glaucoma. And in the emergency, we should give intravenous mannitol to rapidly decrease the IOP. Our next question is a male patient with a history of the hypermature cataract. Look here, hypermature cataract present with sudden onset pain, redness, photophobia in the right eye. In examination, there is deep anterior chamber with raised IOP. The left eye is normal. What is the likely diagnosis? The options are phacomorphic glaucoma, phacotoxic glaucoma, phacolytic glaucoma, and the phacoanaphylactic uveitis. So the correct option here is the phacolytic glaucoma. So how we will differentiate between the phacomorphic and the phacolytic glaucoma? Look here, cataract and the glaucoma with shallow anterior chamber. With shallow anterior chamber, this will be phacomorphic. Look here that this was the deep anterior chamber, and cataract glaucoma with the normal or the deep anterior chamber, this is phacolytic glaucoma. These are very important points. Our next question is, a young patient with history of using glasses for the past 10 years comes with complaint of photopsia and a sudden loss of vision in the right eye. Which of the following tests should be done? The patient is using glasses, so it means mostly myopic. Young patient are mostly myopic, and now he is presenting with vision loss and also photopsia. What test should be done? Indirect ophthalmoscopy should be done. The option delta is correct to rule out RD. The next question is, a 35-year-old patient of insulin-dependent diabetes mellitus on insulin for the past 10 years complains of gradual progressive painless loss of vision. What is the most probable diagnosis? Diabetic patient on insulin, and the vision loss is gradual, progressive, and painless. That is very important. The options are cataract, vitreous hemorrhage, RD, tractional retinal detachment not involving the macula. So whenever there is gradual progressive loss, painless loss in diabetes, the most suitable option is cataract. If there was any other findings like sudden vision loss, there were hemorrhages, we can think of the other options. Our next question is, a 30-year-old male with history of headache is sent for the fundus evaluation. On examination, he was found to have the generalized arterial attenuation. Look here, with multiple cotton wool spots and the flame-shaped hemorrhages in both the eye. The most probable diagnosis is, look here, young patient with headache and these fundus findings: arterial attenuation, cotton wool spots, flame-shaped hemorrhages. All these are pointing towards the hypertensive retinopathy. Okay.